Gallstones, why the pain hits suddenly and when it's an emergency. Imagine finishing dinner, feeling completely normal, and then a deep, steady pain starts under your right ribs. It builds over minutes. Changing position does not really help. Going to the bathroom does not fix it. The pain may creep toward your back or right shoulder, and nausea can arrive with it. Then, after an hour or two, it may fade almost as suddenly as it began. That pattern can happen when a gallstone briefly blocks the pathway out of the gallbladder. And one of the confusing things about gallstones is that many people have them for years without knowing it. The stones themselves are not always the problem. The trouble usually begins when one moves into the wrong place. The gallbladder is a small pear-shaped organ tucked beneath the liver. Its job is simple but useful. It stores bile, a digestive fluid made by the liver. When you eat, especially when the digestive system needs help handling fat, the gallbladder squeezes and sends bile through small ducts into the first part of the small intestine. Gallstones are hardened pieces of material that form inside the gallbladder. Most are made mainly from cholesterol. Others are pigment stones, which contain more bilirubin, a substance produced when red blood cells are broken down. Stones can be tiny like grains of sand, much larger, or somewhere in between. A person may have one stone or many. So why do they form? Bile is a mixture. It contains cholesterol, bile salts, bilirubin, water, and other substances. If that balance changes, certain components can begin to crystallize. Over time, those crystals can grow into stones. Gallstones may also be more likely to form if the gallbladder does not empty effectively or often enough. This is important because a gallstone can sit quietly in the gallbladder and cause absolutely nothing. These are often called silent gallstones. They may be discovered by accident during an ultrasound or scan done for another reason. In many people, silent gallstones never need treatment. Symptoms usually begin when a stone blocks a duct. Picture the gallbladder as a small storage pouch with a narrow exit. When the gallbladder contracts, bile is supposed to flow through that exit. If a stone becomes lodged there temporarily, pressure builds inside the gallbladder. That produces the classic gallbladder attack, also called biliary colic. Despite the word colic, the pain is often not a brief cramp that comes and goes every few seconds. It is commonly described as a strong, steady pain in the upper right side of the abdomen or in the upper middle abdomen just below the breastbone. It may spread to the back or the right shoulder blade. Nausea and vomiting can occur. An attack may begin after a substantial meal and may happen in the evening or at night. But that does not mean every episode of upper abdominal pain after food is a gallstone attack. Reflux, stomach ulcers, pancreatitis, muscle pain, heart problems, and several other conditions can create symptoms in a similar area. Symptoms alone cannot safely diagnose gallstones. The duration of the pain also matters. A typical, uncomplicated attack may settle when the stone shifts and the blockage clears. But pain that persists for several hours, especially if it is getting worse or is joined by fever, chills, jaundice, or repeated vomiting, raises concern for a complication and needs prompt medical assessment. One common complication is acute cholecystitis. That means inflammation of the gallbladder. It often happens when a stone stays stuck at the gallbladder outlet instead of moving away. The gallbladder becomes swollen and inflamed, and infection can sometimes develop as well. The pain may become more persistent, and the upper right abdomen may be very tender. Fever and feeling generally unwell can occur. A stone can also leave the gallbladder and enter the common bile duct, the main channel that carries bile toward the intestine. If it blocks that duct, bile may back up into the liver and bloodstream. The skin or whites of the eyes can turn yellow, a sign called jaundice. Urine may become dark and stools may become unusually pale. If bacteria grow in a blocked bile duct, a serious infection called cholangitis can develop. This can become life-threatening and requires urgent hospital treatment. There is another nearby structure that makes gallstones especially important: the pancreas. The pancreatic duct and bile duct meet near the entrance to the small intestine. A small stone passing through this area can sometimes block pancreatic drainage. That can trigger acute pancreatitis, an inflammation of the pancreas that often causes severe upper abdominal pain and may require hospital care. So gallstone disease is not one single experience. At one end are silent stones that cause no symptoms. Then there are intermittent gallbladder attacks. And at the more serious end are inflammation, infection, bile duct obstruction, and pancreatitis. Who is more likely to develop gallstones? Risk rises with age. Gallstones are also more common in women, partly because estrogen can influence cholesterol levels in bile and gallbladder function. Pregnancy can increase risk for similar reasons. Family history matters, which tells us that genetics also play a role. Body weight is another factor. Obesity is associated with a higher risk of cholesterol gallstones. But there is an important twist: very rapid weight loss can increase the risk too. During fast weight loss, the liver may release more cholesterol into bile, while the gallbladder may empty less effectively. That is one reason crash diets and very low-calorie plans can create problems even when the long-term goal of improving metabolic health is reasonable. Certain medical conditions can also raise risk. These include diabetes and insulin resistance, some intestinal diseases such as Crohn's disease, cirrhosis, and conditions that cause increased breakdown of red blood cells. Some people develop gallstones without any obvious single cause. One detail that often causes confusion is the difference between having gallstones and having gallstone disease. An imaging report can show stones, but the stones may not explain the symptoms that led to the scan. That is especially true when the symptoms are vague. Bloating, belching, indigestion, nausea after meals, or a sense of fullness can occur in people who also happen to have gallstones, but these symptoms are not specific enough to prove that the gallbladder is responsible. They can come from many other digestive conditions. This is why doctors pay close attention to the pattern of pain rather than assuming that every digestive complaint is caused by a stone seen on ultrasound. The same caution matters with shoulder or back pain. Gallbladder pain can be referred, meaning the brain perceives pain in an area away from the organ that is actually irritated. That can explain discomfort near the right shoulder blade. But ordinary muscle strain, spinal problems, lung conditions, and other causes can produce pain there too. Location is a clue, not a diagnosis. Another useful distinction is between cholesterol stones and pigment stones. Cholesterol stones are linked to changes in the cholesterol balance of bile and to how the gallbladder empties. Pigment stones form through different chemistry involving bilirubin and are more strongly associated with some liver diseases, bile duct infections, or conditions that cause increased red blood cell breakdown. For most viewers, the exact stone type will not change what an acute attack feels like, but it helps explain why gallstones do not have one single cause. There is also a reason tiny stones are not necessarily harmless. A very large stone may stay inside the gallbladder, while a smaller stone may be able to slip into a narrow duct and create an obstruction. Size alone does not tell you how dangerous a situation is. Location and blockage matter more. And if a scan says there is sludge, that is not quite the same as a fully formed stone. Biliary sludge is thickened material in bile that can contain microscopic crystals. It may disappear, remain stable, or contribute to stones and complications in some people. Whether it needs action depends on symptoms and the clinical context, not on the word itself. Having risk factors does not mean someone will definitely get gallstones. And not having those risk factors does not rule them out. Risk factors change probability, they do not make the diagnosis. If gallstones are suspected, the first step is usually a conversation about the pattern of symptoms and a physical examination. A clinician will want to know where the pain is, how long it lasts, whether it spreads, what seems to trigger it, and whether there has been fever, vomiting, jaundice, or previous episodes. Blood tests can look for signs of inflammation or infection and can show whether the liver, bile ducts, or pancreas may be involved. But blood tests do not directly show the stones. For that, ultrasound is usually the key first imaging test. It uses sound waves to create pictures of the gallbladder and can detect many gallstones without radiation. It can also show clues that the gallbladder is inflamed. Sometimes the question is not simply, are there stones in the gallbladder? The more important question may be, has a stone moved into the common bile duct? In that situation, additional imaging such as magnetic resonance cholangioppancreatography, often shortened to MREP, may be used. This is a specialized MRI technique that can show the bile ducts. A CT scan may be useful when doctors are looking for complications or considering other causes of abdominal pain, although some gallstones do not show well on it. Another test, called a HIDA scan or cholecystitis, can track how bile moves through the biliary system. It can be helpful when acute cholecystitis is suspected, but the diagnosis is still uncertain after initial testing. There is also a procedure called ERCP, short for endoscopic retrograde cholangiopancreatography. The name sounds intimidating, but the basic idea is this: a flexible camera passes through the mouth into the small intestine, and the bile duct can then be accessed using specialized instruments. ERCP is not simply a routine test for everyone with gallstones. It is especially useful when doctors need to remove a stone that is stuck in the common bile duct or treat another obstruction. What happens after the diagnosis depends on what kind of gallstone problem a person actually has. If gallstones are found by accident and have never caused symptoms, treatment is often not needed. Removing every silent gallstone would expose many people to surgery without a clear benefit. But once gallstones repeatedly cause typical attacks, the situation changes. The usual definitive treatment for symptomatic gallstones is removal of the gallbladder, an operation called cholecystectomy. That can sound dramatic at first. Why remove an entire organ instead of just taking out the stones? Because the gallbladder is the place where the stones formed. If the gallbladder remains, stones can form again. Removing the gallbladder removes both the current stones and the environment where they are likely to recur. Most gallbladder removals are performed laparoscopically. Instead of one large incision, the surgeon works through several small openings using a camera and narrow instruments. Many uncomplicated procedures are done with a relatively short hospital stay, and some people go home the same day, depending on their situation and local practice. Sometimes an open operation is needed, especially when there is severe inflammation, scarring, unusual anatomy, or a complication during laparoscopic surgery. The exact approach is a surgical decision based on the individual case. Can you live normally without a gallbladder? Yes. The liver still makes bile. The difference is that bile is no longer stored and concentrated in the gallbladder. Instead, it flows more continuously from the liver into the intestine. Most people can digest food normally after recovery. Some notice softer or more frequent stools for a period of time, and a smaller group may have longer-lasting digestive symptoms that should be discussed with a clinician. If acute cholecystitis develops, hospital treatment may be needed. Care can include fluids, pain control, and antibiotics when infection is suspected or present. Guidelines commonly support early laparoscopic gallbladder removal in people who are suitable for surgery rather than repeatedly treating the inflammation and leaving the diseased gallbladder in place. If a stone is blocking the common bile duct, ERCP may be used to remove it. Gallbladder surgery may then be recommended as part of preventing future episodes, depending on the person's condition. There are medications that can dissolve certain cholesterol gallstones, but this is not a quick or universal solution. They may take months or years to work, do not work for every type of stone, and stones can return. These treatments are generally reserved for selected people who cannot have surgery or for other special circumstances. And this is where online health claims can become risky. You may see gallbladder flushes or liver cleanses promoted as a way to dissolve or pass gallstones using oils, juices, herbs, or fasting. Reliable medical evidence does not show that these cleanses remove established gallstones. They can also cause nausea, vomiting, diarrhea, and abdominal pain. More importantly, relying on a cleanse during a true obstruction can delay medical care for a condition that may become dangerous. That does not mean lifestyle is irrelevant. It means lifestyle has a different role. For prevention and long-term health, maintaining a healthy weight is useful. If weight loss is appropriate, gradual and sustainable loss is safer for the gallbladder than rapid crash dieting. A balanced eating pattern that includes fiber-rich foods such as vegetables, fruit, legumes, and whole grains is reasonable. Regular physical activity supports overall metabolic health as well. Healthy fats do not need to be eliminated completely. In fact, normal gallbladder emptying is part of healthy physiology. But if someone already has symptomatic gallstones and notices that very large or high-fat meals repeatedly trigger pain, their clinician may suggest temporarily modifying meal size or fat intake while waiting for definitive treatment. That is symptom management, not a cure for the stones. There is no single gallstone diet that reliably dissolves stones. And a food that triggers symptoms in one person may not trigger them in another. The safest approach is to avoid turning a temporary symptom strategy into an extreme, nutritionally restrictive diet without professional guidance. If you are talking with a doctor about possible gallstones, a few questions can make the visit more useful. Ask whether your symptoms actually fit biliary colic or whether another cause needs to be considered. Ask what the ultrasound shows: stones only, signs of inflammation, or dilation of a bile duct. Ask whether blood tests suggest involvement of the liver or pancreas. If surgery is being discussed, ask why it is recommended in your case, how urgent it is, whether a laparoscopic approach is expected, what recovery usually looks like, and what symptoms should send you back for urgent care before the operation. If a stone may be in the common bile duct, ask whether MRP, endoscopic ultrasound ERCP, or another test is appropriate. The best sequence depends on the probability of a duct stone and the resources available. And if you take prescription medicines or have other major health conditions, make sure the treating team knows. Do not stop or change prescribed medication on your own because you think it is affecting the gallbladder. Medication decisions should be individualized. What about complications if gallstones are ignored? Many silent stones stay silent. But symptomatic disease is different. Recurrent blockage can lead to repeated attacks. A persistent obstruction can inflame the gallbladder. A stone in the common bile duct can cause jaundice or infection. A stone at the shared drainage point can provoke pancreatitis. Rarely, severe inflammation or infection can damage the gallbladder enough to cause tissue death, perforation, an abscess, or widespread infection. These are not reasons to panic every time the stomach hurts. They are reasons to respect persistent or escalating symptoms and get evaluated rather than trying to diagnose yourself from a symptom list. So when should you seek medical care? If you have a new episode of significant upper abdominal pain, especially pain under the right ribs or in the upper middle abdomen that lasts more than a short time, contact a healthcare professional for assessment. If attacks keep returning, even if they eventually disappear, that pattern deserves evaluation. Seek urgent medical attention if abdominal pain lasts for several hours, is severe or worsening, or comes with repeated vomiting, fever, or chills. Jaundice, dark urine, or pale stools also need prompt assessment because they can signal bile duct obstruction. And some situations are emergencies. If severe abdominal pain is accompanied by high fever, shaking, chills, confusion, fainting, marked weakness, difficulty staying awake, or you feel rapidly and seriously unwell, seek emergency medical care immediately in your country. Severe persistent pain with jaundice or uncontrolled vomiting also warrants urgent emergency assessment. Do not drive yourself if you are faint, confused, or severely ill. Chest pain, shortness of breath, sweating, or pain that could represent a heart problem should also be treated as an emergency rather than assumed to be gallbladder pain. Upper abdominal discomfort can occasionally overlap with symptoms of a heart attack, especially in older adults and people with diabetes. The most useful thing to remember is that gallstones are not automatically dangerous, and they are not automatically harmless. A silent stone sitting quietly in the gallbladder may never matter. A stone that repeatedly blocks the gallbladder outlet can cause painful attacks. A stone that blocks the bile duct or pancreatic drainage system can become a medical emergency. The difference is not the size of the word gallstone. The difference is what the stone is doing. For most people with symptomatic gallstones, modern treatment is straightforward and well established. Doctors confirm the pattern, use blood tests and imaging to look for complications, and choose treatment based on where the stone is and how much trouble it is causing. When gallbladder removal is recommended, it is because taking out the organ that forms and stores the stones is usually the most reliable way to prevent the same problem from returning. And if you happen to learn that you have silent gallstones, that finding does not mean you need to rush into treatment. It means you should understand the symptoms that would change the picture and discuss your individual risk with a healthcare professional. This information is for general education and cannot diagnose the cause of abdominal pain in any one person. If your symptoms are new, persistent, severe, or worrying, professional medical evaluation matters. Gallstones are a good example of a condition that can be quiet for years, painful for hours, and occasionally urgent. Knowing the difference between those situations is far more useful than trying to memorize every symptom. If there is one takeaway, it is this: pain that comes and goes may still deserve attention, but pain that persists or arrives with fever, jaundice, or serious illness should never be brushed off. The sooner the right problem is identified, the sooner the right treatment can begin.